First, I would like to introduce Dr. Joy Desai. He is the director and head at the neurology clinic at Jaslok Hospital, Mumbai. He has been a DNB teacher for as long as I can remember. He is a consultant neurologist at the Sir H.N. Reliance Hospital. And of course, his research is primarily in sleep and epilepsy. He is a founder member of Sleep Associates, which have a unique Rajkot connection. I am sure he will mention it. So welcome Joy Desai sir, and let's look forward to his talk.
Yeah, thank you Komil for that very kind introduction, and thank you organizers for asking me to be here. It's a great pleasure to be amongst friends and previous colleagues and classmates. This is a subject close to my heart, and I hope I can incite some interest in what I think is a flagging understanding of health and sleep. Now we all know that sleep is not a passive process of disconnection from activity, and it's characterized by a process that consists of a biological change in rhythmic alterations in the brain while we sleep. And we know that if you look at the quantum of 7 to 8 hours of sleep, it's characterized by repetitive sleep physiologies that we call a hypnogram, and these sleep physiology consists of 75% of what's called non-REM sleep, and the rapid eye movement sleep called REM sleep, which is commonly designated with dreaming. We now know that maybe in stage 3 of non-REM, dreaming can also occur, so this distinction is not very rigid and it's a bit fluid. So why does the brain actually sleep, and what is sleep doing? Now if one characterizes this standard designation, then non-rapid eye movement sleep is characterized by a progressive decrease in spinal reflexes. There is a reduction in heart rate and breathing. The brain temperature and cerebral blood flow comes down. There is an increase in hormone secretion, for example, growth hormone, but many others. And the EEG is characterized by a synchronization. So when we say a synchronized EEG, it means that the fast activity that you see when you're awake gradually becomes slower, and with every stage of non-REM sleep, the EEG is slowing. So what happens when you are in rapid eye movement sleep? In rapid eye movement sleep, the reflexes remain absent, but what's distinct, and this was discovered in 1952-1953 by Aserinsky and Dement, eyes move very rapidly, the breathing is stertorous, but the rest of the body rest of the soma, it means all the somatic muscles are completely atonic and silent. And this is an evolutionary need, because if this was not silent, we would enact our dreams, and that can be difficult. This becomes abnormal in rapid eye movement disorder. But the paradox is that in REM sleep, the cerebral blood flow actually goes up and the body temperature increases. And the EEG, which was very synchronized and slow, is now looking very much like you are awake. Because of this disparity we know that REM sleep is a part of deep sleep along with N3, yet there is a paradox in the physiology and in the EEG, and hence it's called paradoxic sleep. And classically we associate REM with dreaming. Now each of these, to any neurologist who knows how to read an EEG, has an EEG signature. So you know that in stage 1 there is a bit of slowing, in stage 2 you get K complexes and spindles, in stage 3 there is theta delta slowing, and in REM sleep again the EEG mimics the activity of being wakefulness. The distinct thing about the 5 or 6 hypnograms as we lapse into sleep is that in the initial half there is a greater amount of non-REM sleep, and in the latter half there is a greater amount of REM sleep. So being a late sleeper or being an early awakener may both be deleterious to the quantum of deep sleep that you're getting, something to think about. So I'm often asked this question that, Doc, as we grow older, all of us sleep less. And this is all steeped in old literature, and I'm not sure how much of this literature should be taken at its face value. But what we do know is that the percentage of time spent asleep in bed is shorter in older people. So once you are a septuagenarian and an octogenarian, I'll get there in maybe about 7 or 8 years. Many of you in this room might be just knocking on that door. So what happens is that deep sleep becomes less, REM sleep also becomes shorter, and there is a greater amount of time that we are spending asleep. So that means there's a greater time that we are spending awake in bed, and that greater amount of time being awake in bed is called vaso. Now we know that slow wave activity is a EEG power between 0.5 and 4 hertz. And it's fairly deep in the early part of sleep, and it decreases as we get into sleep later during the night at the time when REM sleep quantum is greater. So this is a table that shows you how this can change. So it's very different. Slow wave sleep for a young adult constitutes about 23%, but here is the horror that it's only about 5% in not very fit older people. And I'm saying this with some clarity because I think that if your physiological health is good, even an older person shouldn't have this 5%, should have 15 to 20%. And that's what happens to REM sleep too. REM sleep also decreases. And we now have some very alarming data that if your REM quantum gets lowered as we grow older, it's a reflection of cognitive decline. And the two are associated, and science is trying to find out how these two are associated. So there's a greater time spent awake, a greater fragmentation of sleep in older people. There is less time spent in N3, and essentially what we are saying is that older people are not getting enough restorative sleep. So what is restorative sleep? So this is just a diagrammatic expression of what I said earlier, that a greater time of older people is spent awake, and you can see that wakefulness, the columns of wakefulness are greater, and the REM periods are longer in younger people. And therefore in older individuals, perhaps part of the decline of physiological health is related to how we are sleeping. And that should pose some thought for all of us. We all talk about investing in diet, we all talk about investing in exercise, we all talk about investing in stress management and social connectivity. But we don't realize that we may be neglecting sleep as an important pillar that's a determinant of our physiologic health. And this declining sleep efficiency should be a cause for concern. So for many of you who are physicians, we all learned this in medical school, but maybe it's a quick revision that may be needed. What really happens when you're sleeping? So it's a bunch of neurotransmitters called the ascending arousal system and the descending sleep promoting system. So the arousal system is constituted by various neurotransmitters. There's acetylcholine, there's norepinephrine, there's serotonin, and there's dopamine, and there's histamine. And then there is a peptide called orexin. So it's just these six. These six are wired in such a way that when we are awake, they are at their peak. And when it's time to go to sleep, their levels tend to dwindle in the brain. And there is a region of the hypothalamus called the VLPO, the ventrolateral preoptic area of the brain, that starts secreting GABA and galanin. And these two systems, the arousal system, which has this key population, cholinergic neurons, noradrenergic neurons, serotoninergic neurons, dopaminergic neurons, histaminergic neurons, and the neuropeptide orexin. So it's fairly simple, it sounds complicated, but it's pretty simple. Now this part is strategically located in the brain, just above the midbrain in its confluence with the hypothalamus, and that's the diencephalic network that keeps us awake. Now this network is the arousal system. The ventrolateral preoptic area located here inhibits all of these neurotransmitters by producing GABA and galanin. And this works like a switch. So it's a flip-flop switch. When you're awake, it's because the arousal neurotransmitters are all flush into the brain. When you want to go to sleep, they get depleted, and it's GABA and galanin that flushes the brain. So how does the brain decide that this is what it's got to do? So this regulation is by a simple process. It's two processes. One is the circadian process, and the other is the homeostatic process. So if you are sitting in this lecture and listening to all this and writing notes, while your brain is being very active, the basal forebrain is accumulating adenosine. And this adenosine will reach a critical level at about 9:30 or 10. You'll start yawning and you'll say, okay, buddy, it's time to go to bed. So if you have your coffee just now at about 4 o'clock, 4:30, 5, just now you had some coffee. Coffee's got a half-life of 6 hours. It's going to go and block these adenosine receptors. And maybe tonight, if you just had coffee outside, you're not going to be able to use the homeostatic process to sleep because of late coffee. So if you like your coffee, it's before 3 o'clock in the afternoon. The other process is the circadian process, which is driven by the secretion of melatonin. So when the sun sets and the ambient light falls, again in today's time, ambient light doesn't fall. You can look at all the lights in this room. So at sunset, the light doesn't fall, but if you were in nature, if you were in a rural environment and ambient light falls, then the fall in ambient light changes the signaling from the retina to the retinohypothalamic tract, and it signals the onset of secretion of melatonin. So melatonin starts at about 7 in the evening, it peaks at about 1 o'clock in the night, and it depletes by about 4 a.m. in the morning. So melatonin is the synchronizer. As we grow older, these melatonin-nergic neurons fail. And that's one of the reasons why older people don't sleep so well. So what's the brain doing when we are sleeping? Sleep is vital for memory consolidation. It is instrumental in regulating emotions. It regulates blood pressure. Now you all heard about blood pressure and diabetes all throughout the day. It normalizes blood sugar and fat storage. It maintains white matter integrity. It ensures optimal CSF absorption. And it keeps the brain clean from amyloid and tau via the solely nocturnal glymphatic system. You heard the MC talk about detox in sleep. There is actually a detox. We discovered this detox or excretory mechanism in 2013 when Mike and Nedegard described the glymphatic system. She called it the garbage truck of the brain, which is a nice appellation. It means that only when you are sleeping, your brain's being cleared of potentially toxic end products of brain metabolism. Some of them are identifiable like amyloid and tau. There is one more, TDP-43, and we are discovering others. All of them are excreted when we sleep. And most importantly, sleep maintains the blood-brain barrier permeability. So if you have a sleep disorder like sleep apnea, for example, your blood-brain barrier permeability may not be very good. And if you have a stroke, or a brain bleed, you are highly likely to develop peristroke or peri-bleed massive edema that occurs in those who have a sleep disorder, either circadian asynchrony or they have sleep apnea. So how's the brain making memories when you're sleeping? So when you're sleeping, there is a symphony in non-REM sleep of electrical changes that occur in a hierarchical manner. So the hippocampus is like a small pen drive. While you're listening to me, your hippocampi on both sides are accumulating information. When you sleep at night, the hippocampus develops this rhythm. It's called hippocampal ripples. And this then in stage 2 of sleep, via the spindles, it yokes to slow wave oscillation of stage 3. So when this thing happens, this electrical harmony of transition is the period when memories are being formed. So all your temporary storage experiential engrams are transferred to the frontal and parietal lobes for consolidation. Relevant memories get consolidated, irrelevant ones get wiped out. And there is the complex biological process of recognition of which ones are relevant based on the amplitude and density of neuronal firing in the hippocampal neurons at that time. We have lots of evidence, I will not get into that. But if you have a sleep disorder, then your memory suffers. So if you're forgetful, you have to ask, am I sleeping right? So these 3 waves, hippocampal ripples, slow wave oscillation spindles, yoke together in sleep to transfer memories from temporary storage in the hippocampus for permanent storage in your cortices. So not so difficult, right? It's biology simplified. So what happens when we are growing older? We said that in older people, this physiology of sleep is gently failing. If that's happening, then this coupling becomes abnormal, and that happens because of brain atrophy in the prefrontal cortex. And all this work has been done by Matthew Walker's group. So when you're older, if your mesial prefrontal cortex shrinks, then this coupling is poor. And this coupling is poor because the slow wave oscillator origin is from the prefrontal cortex. So if you have a smaller prefrontal cortex, the oscillations are not happening. And that's why older people are getting forgetful. It's not necessarily a disease. How do we know this? This fantastic study by Matthew Walker, Bryce Mander, and they've shown that this is the prefrontal cortex. What you see in red are younger people, in blue is older people. Older people have prefrontal atrophy. So the next question you should ask me is, Doc, what can we actually do to stop our prefrontal cortex from atrophying as we grow older? So what makes this prefrontal cortex susceptible and vulnerable? Trauma, aging, sedentariness, lack of exercise, too much alcohol, depression, and loneliness. So it means that all of us need to exercise, all of us need to stay away from alcohol if we can, maybe a little bit. We all need to have social connectivity, and we all need to avoid head injury, and we all need enthusiasm and passion. So this thing about being motivated, so loss of purpose is a very big thing that makes your brain shrink. So having a purpose, having goal-directed behavior, a good social network is good for this prefrontal cortex. And if your prefrontal cortex is good, less likely that you will sleep badly, less likely that your memory will be poor. The other thing we know is that REM sleep is an emotional regulator. So that means and Matthew Walker calls it's a fantastic term. It means overnight therapy. That means every night REM sleep is your psychiatrist. And that nighttime REM sleep is making your brain emotionally stable. How do we know that? We know that from studies that they have done. And it shows that if you had, say, a very traumatic experience with your boss or with your wife or with your son or your daughter, or whatever, there is an emotion and there is a memory. But when you have REM sleep every night, that emotion gets depleted and only the memory remains. So every time you remember the event, you are not confounded by the emotional accompaniment. So sleep is a moderator of emotional stability and salience. And that's the reason why our older people always said, if you have a problem, don't argue now, sleep over it. Because when you have REM sleep, your emotions are calmer, and the next day you are ready to negotiate. I said that blood pressure is regulated by sleep. Now, how's that? Nobody told us that in med school. Nobody told me this. But there's a study by Adam Krauss. Adam Krauss also works with Matthew Walker. This is 2022. You should look this up. And what we know is that if anybody in this room is made to sleep less by 1.5 hours for 14 consecutive days, your systolic and diastolic pressure will rise. And that's because there is a network. The prefrontal cortex regulates the insula and the amygdala. And we now have fantastic studies to show that insular and amygdalar reactivity in sleep is a regulator of blood pressure. And there is a cardia study done by Meghna Mansukani and Viren Somers from Mayo Clinic, which shows that just 1.5 hours of less sleep on a regular basis for a month can increase your blood pressure by 37%. Now that's a horrendous number, okay? And why aren't we reading this? Because the pharma industry doesn't want us to read this. So you've got to know that your lifestyle can regulate your blood pressure. Not everybody who's older needs to be on an antihypertensive drug if you got things right. You all heard so much in the afternoon about insulin and new fancy ways of controlling your blood sugar and your body fat storage. Well, we have data now. This was published in 2023. We have actual proof that the slow wave oscillations, besides other things, are also regulating your blood sugar and your insulin sensitivity. So the insulin resistance syndrome is, amongst other things, also linked to dysfunctional sleep. So if you've got sleep right, then that's one more peg in the insulin harmonization activity. We talked about detox. So your brain has a very fancy washing machine that works only at night. So it's the best biological brain cleaner. We discovered this in 2013, like I told you in October, the garbage truck of the brain. It's called the glymphatic system. It's very simple. here's the artery, here's the vein, this is the interstitium. So when you go to sleep, the brain's interstitium expands in N3. And when this interstitium is expanded by 40%, the cerebrospinal fluid is slowly lapping from the arterial to the venous side. And the directionality of the flow is regulated by this astrocyte, which has aquaporin 4 on it. And we will tell you how it is the master of this biology. Okay? So this system is called the glymphatic system. So what do you need to know? It is a unidirectional flow of CSF mediated by the glymphatics only in sleep. As soon as you wake up, the glymphatic stops. If you're sleeping supine or in a lateral position, it optimizes glymphatics. Prone sleeping reduces glymphatic by 40%. Okay? Exercise, intermittent fasting, and they say somewhat low-dose alcohol improves the glymphatic system. I'm not sure about the alcohol bit, so don't take my word for it. When they studied mice, they put whiskey into the mouse abdomen via a syringe. So I'm not sure whether drinking alcohol is good for you, so I've not put it there. Head injury, diabetes and strokes, especially lacunar infarcts and sleep apnea, all of them impair glymphatic efficiency. And this glymphatic is removing amyloid and tau from normal asymptomatic people. So this clearance is important. It requires polarization of this aquaporin 4. So aquaporin 4, if it's on the foot process, then glymphatic function is good. If the aquaporin 4 is on the soma of the astrocyte, then glymphatic doesn't work. So what can we do? So Mediterranean diet, now everything Mediterranean, but I think a diet rich in greens, fruits, and legumes, all of us, even the vegetarian diet without actually too much meat, can do that. Fish oils, exercise, tai chi, meditation, passion, and caloric restriction in the form of intermittent fasting. All of them have been shown to improve the polarization of aquaporin 4. This aquaporin 4 polarization is your glymphatic enhancer. That means you live right, your glymphatic functions better. This enhances amyloid clearance, especially when timing is optimal. And the brain wants to sleep 4 hours from sunset, 10:30, and you should all take notes. I'm not sure how many of you are sleeping at 10:30. You should. And the brain wants to wake up with sunrise, which is 6:30. So insomnia, sleep apnea, fragmentation, and circadian asynchrony can all disrupt this process. This is the diagram for the polarization, and it just tells you what it is. The alarming thing is that if you're sleeping less than 6 hours, when you're 50 or 60, increases the risk of your getting dementia when you are 70 or 80 by 30%. And this is Severin Sabia's study, and there are many other studies. I've not brought all of them here. So what do we need? We need humans to sleep for 7 to 8 hours. It's beneficial when timing is followed, 10:30 to 6:30. Consistency is the secret. You need to treat sleep disorders. Set a routine, because the brain believes in habit. Exercise in the daytime, not in the evening. Limit the window of food consumption to 10 hours. I like people to eat between 9:30 and 7:30, like me, and I hope things can change. Meditate, invest in mindfulness. Now, the traditional understanding of sleep apnea is that this whole thing that is published in New England Journal of Medicine, snoring in sleep, fat person, breathing difficulty, gasping, this is the classic phenotype. But we know that sleep apnea is bad for the brain. It leads to endothelial dysfunction, higher risk of strokes, it augments hypertension, changes diabetes, makes it worse, produces cardiac arrhythmias, makes you gain weight, and impaired glymphatic clearance is implicated in Alzheimer's disease, and we now know that the two are related. And frequent nocturnal awakening changes autonomic stability and can produce syncope, cardiac arrhythmias. It's a strong risk factor for ischemic optic neuropathy and retinal venous occlusions. All this is recent. So if you have a patient with AION and doesn't have giant cell arthritis, you must do a sleep study. If you have a patient with venous occlusions of the retina, you must do a sleep study because they probably have underlying sleep apnea. And OSA worsens neurodegenerations like Parkinson's disease. In fact, at the AAN this year, in 2025, there was a presentation by a neurologist from Baltimore, I think, that every patient with Parkinson's disease should be screened for sleep apnea, because sleep apnea can make the spread of synuclein worse. So this is new information, it will come into the guidelines. This is one of my anesthesiologist's mothers who came to me at the age of 69 with fatigue, forgetfulness, daytime sleepiness, lethargy, loss of motivation, poor sleeper, and she had signs of early Alzheimer's disease. When we did her PET scan was very typical. There was bilateral temporal and bilateral posterior parietal hypometabolism on the PET, very typical of Alzheimer. And look at her sleep study. She had a total index of 17, but her supine index was 34. That in REM sleep was 44 per hour. And she had very, very severe oxygen desaturation, lowest of 82, and she spent 15 minutes of her sleep time below 90%. So if you look at most of our cognitively impaired individuals, they're not breathing well. And I have lots of people from my friends in the audience in the front row who have also had the same experience now of having looked at them. So just having sleep apnea with an AHI of more than 20 can increase your stroke risk by 3.5 times, irrespective of diabetes, hypertension, or your abdominal girth. This is one of my patients. You can see the white matter disease. He had strokes despite being on medications for hypertension, diabetes, and antiplatelets. And this is his sleep study. He did a respiratory study. He had an AHI of 29, and his longest apnea was 29 seconds. He had 202 episodes of desaturation and 8 episodes below 90%. So you can know that this can happen. Do we have objective information that corroborate this? This is the Oscar Del Bruto study, 2017. They looked at 104 randomly selected Inca descendants living in their reserves in Ecuador. They underwent PSG and a sleep questionnaire. And if you look at their multivariate analysis, sleep apnea is associated with moderate to severe white matter hyperintensities on MRI. And this, so when you grow older, if you look at an MRI scan that is looking white, you need to just ask how they are sleeping, because it's very likely that they also have underlying sleep disordered breathing. And we have 2 studies now to show that treating sleep apnea early can improve the white matter. There's a Castronovo study that shows that. So sleep apnea is an independent risk factor for producing white matter dysfunction, independent of hypertension, diabetes, obesity, and sedentariness. It can also make you, this has been shown in some Korean studies, this is the Korean study, and it can also make you look older. So one of the things is that the worry about sleep apnea is that it is producing a biological change in your sirtuins and in a new aging protector called clotho. So if you have sleep apnea, your clotho levels go up and it changes the biology of senescence through suppression of sirtuins. And so in simple words, if you have sleep apnea, you're not treating it, you're going to age faster. So in what settings? This is my last slide. When do we screen for sleep apnea for neurologists? Unexplained syncope, uncontrolled hypertension, refractoriness in seizures, isolated nocturnal seizures. I presented a paper on this just about a few months ago. Unexplained drowsiness in the ICU when metabolics have been corrected, lacunar strokes, white matter abnormalities, and now NPH and Alzheimer's disease. So we have experience now to show that almost virtually every patient who has normal pressure hydrocephalus, if you screen them, they often have geriatric sleep apnea. And in patients with minimal cognitive impairment, whether young or old, when other screenings have been done, you must take a sleep history, because here's something that is a modulator of how they're sleeping. Thank you very much for your time, to take time out to come and listen. And I'm delighted to be here. Thank you.